a heavy topic. I wish we had a couple weeks to focus on it. So, in order to kind of compact time, we're going to try something different. We have this narrated PowerPoint. You can also flip through the slides, but I want you to prepare by watching or reading the slides before you come to class, um, because we're going to devote the class time to a speaker and some discussion groups that are very important. This is a quote from C.S. Lewis, who wrote the Chronicles of Narnia. He was also what they call a Christian apologist. He wrote about Christian theology, um, but he wrote a very famous book called A Grief Observed, about his wife Joy, who died after they were married 3 years. But he describes grief as fear, a fluttering in his stomach, the same restless yawning I keep on swallowing. Um, He says, "No one has ever told me that grief felt so like fear. I'm not afraid, but the sensation is like being afraid." So here are the objectives of the lecture. There are a lot of objectives, so we're going to zip through this. I hope you don't find it too frustrating, but I will focus on the high points, and hopefully you'll do more reading to bolster your knowledge. So loss, defined as the undesired change or removal of a valued object, person, or situation. I want to make the point here that we're focusing on death and dying, but there are many kinds of loss in life, and especially with some older patients, you will find they've experienced so many losses in their life that they're really living in a different era, or that the kind of the best time in their life they feel has passed, and they're really kind of stuck back a few decades before. So there are different categories of loss. There are probably 10 more categories, but I want you to read these words and think about what they mean. So if you had a test question, you'd be able to say, oh, that's what that is. But actual versus perceived. I can actually lose a loved one, or I can perceive I have. Maybe they're not talking to me anymore. Maybe I had a strong communication where somebody was calling me every day and they've gotten busy. I might perceive that as a loss, but actually it's my perception. It's hard put to find a good example right now, but think about that. Um, and of course, there's physical versus psychological loss. Again, going back to a relationship, if you end a relationship, the person may still physically be there, but you've psychologically lost connection. Um, Loss of aspects of self. People who've had strokes, lose many aspects of themselves sometimes. Environmental loss can be sort of more tangible. Your house burns down or something of that nature. And then loss of significant relationships. Some of these categories overlap. But I want you to think about actual versus perceived and physical versus psychological. So grief, many definitions again, but you need to know it really is both physical and psychological. And some definitions include your spiritual response to the loss. Um, so mourning is a specific word that describes the action or process. And I would insert the word ritual there too, associated with grief. Bereavement is the mourning or adjustment time that follows a loss. So Engle is a theorist. Well, he was actually a physician, but he described in 1964 three stages of mourning: shock and disbelief. You can't believe the person's dead. What? And you'll see this, unfortunately, as you work as a nurse. Developing awareness, the person may become guilty, sad, isolated, angry, hostile, as they realize that the death has occurred or is about to occur. And then the final stage is restitution and resolution, where the person comes to terms with the loss and figures out how to carry on. So that was Engle, 1964. I'm only going to name two theorists in this lecture. That is adequate for studying, but know, of course, that many people have discussed death. So there are at least four aspects of grieving. There's what we call normal grief. Under that, they have different categories, abbreviated. I didn't write anything after that because it's a short period of grieving. Anticipatory, you perceive the loss before it's going to occur. That often happens in chronic illness. Disenfranchised grief is grief not recognized by others. And that can happen in our society a lot. Somebody dies and you don't even know that that person's spouse has died or that person's significant other has died, because there's really no way of knowing. And, Victorian times, people in England wore black. They had a mourning period. We don't do that anymore. So those are all under the category of normal grief. So they become abnormal when, I would say, things become unresolved. There's a maladaptive reaction. The person's not able to get on with their life. The mourning period becomes very prolonged. Some definitions say the loss, the person denies the loss, the grieving goes on for more than 6 months. I would be really careful with these definitions because every human is different. And I think going back to the C.S. Lewis book, grief is not as, I think, it's not as succinct a process as somebody would have you believe, that somebody can years later remember the loss of a loved one and suddenly become sad again. Is that abnormal? No, that is the way humans are. It's more of a cycle. It's more of a process. So anyway, so I would just know that there is something called complicated grief now. That they thought about putting in the DSM-5, the new diagnostic handbook. It's actually under diagnoses to be considered, and it's just a situation where the person has suffered a loss and a significant period of time has passed, months and months and months, and the person has started to have acute psychological, not acute, but extreme psychological symptoms that impede his or her ability to live. Okay, so factors influencing the loss and grief response. So just like with pain, just like with many sort of psychosocial things about humans, there are a lot of variables. A person's culture is a big variable. The cause of loss or death, if it's unexpected, of course, it's a shock. A person's age and developmental stage. A preschool child may think the person's going to wake up again. They may view this as kind of a Sleeping Beauty cartoon-like thing. There's something called hardiness that people are studying. Some people experience a death and 4 or 5 months later they're back to normal. They've processed it. And is that good? Not necessarily. Is it bad? Not necessarily. Some people just react in a different way. It doesn't mean they haven't dealt with it. Anyway, know that there's different factors that influence grief and loss. So manifestations of grief, they can be both physical or psychological. Sort of things that you're going to see when somebody has a loved one who passes away. Of course, crying. They're going to be talking about it. Their sleep may be disturbed for a period. They may experience a loss of appetite. They might have trouble concentrating. Now, when this extends over a period of time, and I don't want to put a number on what that time is, and the person starts to have severe physiologic symptoms, constant headaches, constant stomach aches, pain that won't go away. They're having suicidal ideation. This can be what we call complicated grieving. And I would just say, if the person's really unable to function, it deserves treatment. And so anyway, there's discussion now about what the label is for this and what the definition is. But complicated versus normal manifestations of grief are what we want you to take away from this. So we're moving to a new topic, end-of-life care. Palliative care is often the umbrella term that covers end-of-life care. It's offering patients a holistic, comfortable care modality. And so holistic means, we're looking at the whole human. We're looking at physical symptoms, but we're also looking at psychological and spiritual care. So hospice care is more focused. It is focused on the end of life care. So back to palliative care. It's an approach that improves quality of life for patients and family. They don't have to be imminently dying. We focus on symptom control and support rather than curing the disease process. We provide pain and symptom management. An example of this that you might not first think of is the CHF patient who has pretty advanced heart failure. They might be placed in palliative care. Really, there's not, short of a heart transplant, there's not anything that's going to fix this situation. And so the patient might be in palliative care. They may be getting psychological support. They're certainly getting a lot of tight symptom management support. They may even be getting counseling, the whole thing. And so, we typically think of cancer patients, but it can be people with chronic diseases who are placed in palliative care. Hospice care, on the other hand, is really focused on the end of life. Its mission is to support the dying patient and their family with the goal of facilitating a peaceful and dignified death. We're trying to emphasize care that improves the quality of life rather than cure. We're going to see some videos on Thursday where we look at this question of care versus cure. It's a concept of care that provides compassion, concern, and support for the dying and their families. So hospice admission has two criteria in this country anyways. The patient must desire the services. The doctor can't just say you're going on hospice care. And a physician has to certify that the patient has 6 months or less to live. It's an interdisciplinary team approach. There are nurses on the team. There are physicians. There might be social workers. There might be other ancillary professionals like respiratory therapy even. And it can be carried out in a variety of settings. It can be in a home where the patient actually goes, a home meaning a care center or a hospital, and it could be their own home. In this country, we most often see hospice care going on in the patient's home, but there are hospice centers. So as we get into this topic of death and dying, and as you as a nurse have the experience of taking care of a dying patient and their family, you need to know from the get-go that it's normal for you to feel grief. It's normal for you to feel many of these symptoms and feelings that I'm discussing right now. So you need to learn how to recognize those. You need to learn how to take care of yourself and develop a support network. You've got the beginnings of a good one with your class. You need to think about developing friendships where you work so that you can process what's going on. It's the only way to avoid burnout. So now we're going to move to the topic of death. Elizabeth Kubler-Ross talked about the stages of grief. Sometimes it's called the stages of dying. In the 1960s, she was very famous at the time, and she had these stages. We do want you to learn them. I'm going to give you my kind of view about this, but the first stage is denial, where the person refuses to believe the diagnosis, may assume kind of an artificial cheeriness, like, oh, I've got lung cancer, but, doc says I've got a chance. Whatever. Okay. Anger. The patient may direct anger towards the staff, the family. Yeah, that's true. You're going to see a lot of angry family members, a lot of angry patients as you work as a nurse. They've gotten bad news. They've got to direct that energy somewhere. Bargaining. At a certain stage in the process, according to Kubler-Ross, people begin to bargain, sometimes with the higher power. If I do this and this, please give me 6 more months or cure my whatever. Or that is a stage that people go through as they grapple with this, according to Kubler-Ross. Depression is her next stage, where people grieve over what has happened and what can't be. They may be hyper talkative, or they may become withdrawn. And the final stage, according to Kubler-Ross, is acceptance. The person is able to come to terms with their loss and then may begin to plan for the future, may begin to seek some spiritual resolution or significance from the event. The thing I want to say about Kubler-Ross, and it's not just me saying this, yes, you need to learn these stages, but do they universally apply to all humans? No. I think in America, well, maybe everywhere, but we have a tendency to, here's your checklist, here's your 5 steps, work through these, and you're going to be okay. Oh, they didn't go through their acceptance step. Well, they haven't accepted the step. Every human is different, and I think we're seeing more and more that there are processes. Everyone has their own way of coming to resolution. I think what Kubler-Ross and others really did in the 1960s is bring the topic of death, dying, grieving out into the public's attention, making it something that we talked about more openly. And so take from her what you wish and think about it. So how is death defined? It's not that easy to define what a dead person is. There's a historical definition. The heart stops beating. There's the heart-lung death definition. There is no more EKG. The heart is not beating. They are not breathing. There's whole brain death, where there's no more EECG activity. And there's the Uniform Definition of Death Act, which has been adopted in most states, and it's supposed to provide a medically sound basis for determining death. They have cessation of circulatory and respiratory function, irreversibility of all functions of the brain, including the brainstem. And anyway, actually, back to this slide. This is actually important. We're going to have a guest speaker on transplant, and so we know now. I do want to make this point. We know now that when a person's heart stops, it can be restarted or it can be mechanically kept going. And so this definition of death is actually a really slippery slope that's interesting to read about. Let's just leave it at that. Okay. So legal and ethical considerations. You won't remember this, but the first quarter in our ethics lecture, we talked about how hospitals who admit patients now have to ask if they have an advance directive, and really they should be providing teaching around advance directives, encouraging patients to fill them out. All right. So there's the concept of do not resuscitate. It doesn't mean do not treat, but it means the patient doesn't want to be resuscitated artificially, chest compression, shocking chemically. They can specify. There's assisted suicide. There's euthanasia, autopsy, organ and tissue donations. These are all some legal and ethical considerations. I don't want to belabor them. Each one could be its own lecture. We are going to have someone speak on organ and tissue donations. In California, anyways, when somebody dies, we call the donor bank. We have to call the California Donor Bank. We don't approach the family. That's left to the donor network. But all deaths are to be reported to the donor network. And they will rule out or rule in whether or not the patient is even an acceptable donor. Assisted suicide is something that's actually become legal in Oregon. There's been a lot in the news about that. Euthanasia is counter to all ethical principles, the American Association of Nursing, the AMA, etc. But it's a term that means, that you're putting somebody to death for so-called for their comfort. Okay. Anyway, so here's a sample do not resuscitate form. It's a little hard to read. It's a very simple one. Some of them are more complicated. They'll specify I want this, but I don't want that. Anyway, that's a typical one, best I could find. So nursing care of the dying person. So you're going to be really involved in meeting not only physiological needs, but the psychological needs of the patient and their family. You may be addressing their spiritual needs. You may be addressing specific cultural needs. So there are different physiological stages of dying. They kind of start 1 to 3 months prior to death, 1 to 2 months prior to death, days to hours prior to death, and the moments prior to death. Again, this could be a whole week's classes, but we're going to see a film about a woman in hospice, and you'll see she's, a month to 1 to 2 weeks prior to death at some point in the film, and you'll see that there are changes occurring. All right, so impending clinical death. There are a lot of things that happen to the body, but it starts to shut down. Sometimes it's a slower, weak pulse. Sometimes the pulse will accelerate for a long period, trying to compensate for what's going on, and then you'll see it slow down. And when it does slow down to that very bradycardic state, it's really a good signal that death is near. And that's often a good time in the ICU to turn off the monitor because the family gets so focused on that monitor. But you're going to see changes in circulation. You're going to start to see some modeling. You're going to start to see that slowed heart rate, and you're going to start to see changes in respiration. They may have periods of dyspnea where they're not breathing. They may do the Cheyne-Stokes breathing. And they say that hearing is the last sense to leave. I don't know how that's been determined, but that is what people say. So you want to think about what you're saying around the dying person, and really, the families pick up on things you say, and they may remember those things you said and kind of intensify them in a way you didn't intend. So you're almost on stage when you're caring for a dying patient. So some key elements for nursing care of the dying. The patient needs to understand their illness. Your job is to be providing that education. Does the patient have any personal experience with death? Do they have any way to sort of anticipate what is happening here? Obviously, you want to be honoring the patient's goals and wishes. And I don't mean in that kind of Make-A-Wish Foundation way. I mean in the sense of, I want to be at home, I want to be alone, I want my family with me, that kind of thing. You want to facilitate communication with the patient's healthcare provider, and you want to make sure that, connect the family with as many resources and supports that you can. So the needs of the dying, freedom from pain is such a huge thing. I'm going to emphasize that again, freedom from pain, freedom from loneliness, sometimes hard in the hospital to provide, conservation of energy, make them comfortable, make life easy for them, maintenance of self-esteem. We talk about reconciliation. This is your time to make amends. This certainly helps those that the person leaves behind. Spirituality and hope are all considered needs of the dying. So the physical care, we want to focus on symptom management. The priority is to meet the physiological and safety needs of the patient. They deserve the same care as someone who expects to recover. We have a little mantra at work, DNR does not mean do not treat. So this person is going to receive the same focus, care, and attention as any patient. So we're going to take care of pain relief, oxygen if it's appropriate, nutritional support, mobility, help them with their bowel movements, their urination, and skin care and hygiene. I think hygiene should be on that list. So your ethical and professional responsibilities for the dying patient. You want to do good. You want to avoid harm. You want to respect the family and the patient's preferences. You should act as a role model to this family of compassion and clinical proficiency. It's a tall order. being a hospice nurse or being a nurse in the ICU where you're dealing with the dying patient. You're the patient's advocate. So psychosocial care. Silence is okay around a family, around a dying person. You want to be a listener. You want to use that therapeutic communication we talked so much about in the first quarter. Open-ended questions. The patient can be confused, disoriented. You may have snippets of lucidity, and then they go back to being confused. You can have some very strange and wonderful conversations with people at the end of their life. Hope and spirituality. This is not the same as religion. People can be very religious and not very spiritual or hopeful, but it is often manifested through religion or other methods. Hope is the expectancy of fulfillment. So people, so say many experts, hope to find some kind of fulfillment at the end of life, and I think that's true. So as a nurse, you want to be trying to facilitate conversations with family, conversations with clergy, trying to acknowledge that this life has been lived and has been a worthy life. Okay, Erickson, the psychologist, equates hope with integrity. By integrity, we mean a sense of wholeness, a sense of completion as a person. And so a dying person's hope includes expecting love from others and the freedom to make choices. A lot of people die alone in the hospital without loved ones around, and so often the nurse is that proxy for the person's whole existence, the whole sense of love. So take that role seriously. Culturally competent care. Every culture has its own view on death and dying, its own rituals. And for the non-English speaking family that you're going to have as a nurse, they're really at risk for not getting the correct information, not being able to express what they need for their family. So you want to be bringing in translators. You want to be using that translator computer screen or phone. You want to be astute about that. So, and then we already discussed this, but different cultures really express symptoms differently and express pain differently. Some are more stoic, some are less stoic. And so avoid stereotyping individuals with different cultural belief systems. You don't really know unless you're walking in their shoes what the belief system is and how this is going to play out. Okay. And so, back to this culturally competent care. There are definitely rituals that different cultures participate in. There are definitely different prayers, different this, different that. But the thing that is so subtle is the harder thing, of course, to see and to work with. What am I trying to say? Different cultures may kind of hide their feelings more. They may be more expressive. And just know that that's there. Okay. All right. Strategies for helping clients die with dignity. Identify personal feelings about your personal feelings about death. Help the clients define their personal feelings about death. Both are important. When you are dealing with patients, you need to kind of really understand what you know and what you think about dying. Anyway, you want to focus on the client's needs. You want to establish communication, relationships with the family and with the patient. You always want to know what the client knows about their illness, and you want to be there to facilitate education and help them to understand what's going on. You want to be honest and direct, and you want to always make time to be available. These are tall orders. So when you're working with a family, and a patient, you want to be empathetic, caring. You want to explain exactly what's happening. Don't mince words. Don't sugarcoat words. Don't use euphemisms or metaphor. They teach us to say, "Your loved one is dying. Your loved one has died." When we use words like "passed away" or "passed" or "gone to a better place," this kind of thing, especially when someone's in a state of shock, that doesn't register. You want to speak slowly. You want to use clear language. You want to encourage patients to participate in their own care as much as possible. And some nurses find that families find it therapeutic for families to give permission to the client to let go. Death can be a very prolonged experience, just like birth, and sometimes families will say, "Okay, it's okay with us if you leave." And I do think I have seen that so many times that the family will step out for a cup of coffee, and the patient expires while they've stepped out. I do think that people will hold on to that very last moment if they can. Yeah, permission to let go is important. So postmortem care, this is, so there's a couple pictures here, I have to warn you, but this is a part of nursing care, is postmortem care. Each agency has its own specific policies. This is kind of general guidelines here. You want to respect cultural and spiritual preferences. So know that in very many religions and cultures around the world, burial has to take place very soon after the patient expires, and so you need to know what the family wants to have done with the body. So when I worked in ICU, I would talk to the family ahead of time. Do you have a mortuary picked out? Do you have a plan? And if they didn't, we had a list of resources, but people that don't have a mortuary picked out, hospitals have a place where bodies are stored for a certain period of time anyway. The morgue. Okay. So helping families after death, you want to provide emotional support immediately after the death, provide grief education, encourage the family to view the body. Sometimes people want to take a lock of hair or something like that. Children should be included in the event if that's what the family wants. When somebody dies and has died in the hospitals I've worked in, we usually either try to clean that room up and put chairs in, maybe some pitchers of water, so that the family can have time to sit with the body and grieve, or sometimes we'll move the body to a room where we know that the family will have time to sit with the patient and be with them. Maybe other family members, we kind of turn off the rules about visitors, and sometimes there'll be quite a few family members who are called and come in, etc. So postmortem care, as a body sits, the blood begins to pool. So that's called livor mortis, that bluish color. There are two other words, rigor mortis, the stiffening of the body, that starts to occur within 2 hours after death. So when somebody dies, you want to lay the bed flat. You want to put the body in a natural position before stiffening occurs. The body will gradually begin to get cold. That's called algor mortis. That's how on CSI they determine the time of death, by the person's core temperature, because it drops. Okay. Care of the body after death. As I said, each hospital has its own rules. You want to create that place where the patient's family can come in and view the body and actually be with each other and to process what's happened. Okay. So after the family leaves, most modern hospitals have a body bag, a kit, a death kit, and it includes identification tags, and these are very important. You want to leave the identification tags on the wrist ID on the patient. There's usually a toe tag that gets filled out. There are different rules about the IV and the Foley catheter, etc. In Alameda County, the coroner gets called for all deaths. So we don't remove anything because there may be an autopsy. I think it's rare, but we leave everything in place. In Contra Costa County, we did it differently. So the body's placed in a bag usually, and then the bag is zipped up, and then tag goes on the outside of the bag also. Anyway. So nursing process review. The following slides are